as doctors, we always need to do what we know is currently the cutting edge best knowledge, but with also the knowledge that we don't know everything. And, that's where research is going in the future.
I had the privilege of interviewing Professor Mark Whiteley, consultant venous surgeon and founder of the College of Phlebology and the Whiteley Clinic. Let's talk all things pelvic congestion syndrome.
With that many women in terms of research and going into the future, with the UTIs that seem to be persistent and can't be solved, I just feel like...
Well, they should all have a transvaginal scan, without doubt.
7 years into my debilitation with pelvic pain, chronic infection and dysautonomia and ME, I'm only just looking into getting a transvaginal scan to diagnose or rule out pelvic venous congestion, a treatable vascular issue often overlooked, which ties into systemic symptoms and metabolic dysregulation. To put it simply, pelvic congestion syndrome, PCS, is a condition characterized by chronic pelvic pain caused by enlarged varicose veins in the pelvic area, primarily around the ovaries and uterus.
But we know if you actually look, I mean, it's absolutely criminal in this country, but also around the world. And I've written a couple of papers on it. And we've just set up a clinic with a gynecologist, the first gynecologist we've actually got interested in pelvic congestion, and she's doubly qualified with us in pelvic congestion and also in endometriosis and all the other moldings. And one of the reasons it's been well known internationally that 1 in 3 women going with any sort of pelvic pain to a gynecologist has got pelvic congestion, but the vast majority get told they've got endometriosis or they're mad or there's nothing wrong with them because the gynecologists are not trained to look for the veins. And if you talk to the gynecologist after they've done laparoscopies and CTs or whatever, and you say, well, don't you notice these big veins? And they go, oh, they've all got them. They've all got them. And they just brush it off. And they're actually seeing the disease. But because they're not trained to look for it, they miss the diagnosis. And I've written lots of papers on this. Just published one that actually showing that almost all the research in the world that's published is in venous literature or arterial literature or radiology literature. Almost none of it. I think it's 11% or so is only gynecology literature. The gynecologists are not interested, but the patients go to see gynecologists because that's where the discomfort is. And so this is a massive problem when we have a really simple test to diagnose pelvic congestion, which is the Holdstock-Harrison protocol transvaginal, which is minimally invasive. It's just transvaginal. Whereas instead, women are having blood tests, usually CT or MRI, and then having a laparoscopy with all the inherent risks, far more expensive, much more risky for the patient. And if CT has actually has also got the cancer risks of the X-rays, they don't need that you can actually tell whether they've got pelvic congestion syndrome or not just with one ultrasound scan done by someone who knows what they're doing in the right positions. It is a huge problem at the moment because what happens is it's not that it's not available, it's just that doctors are not informed with research that's been around for 20 years.
Well, interestingly, I think maybe the statistic of 1 in 3 is even higher because that's 1 in 3 that are going to the gynecologist. I'm in my 7th year, having been thrown from however many urologists and other specialists, and I've always spoken about my pelvic pain and or UTIs. And it's only in the last week or two, off the back of really private specialists, where the GP tried to send me for a scan to the interventional radiologist or the radiology team. It got rejected. And they were like, oh, she needs to see a gynecologist in order to get this scan. And I thought that the wait list for a gynecologist on the NHS is really bad. And then reading all of this, I was like, they might not even know what I've got anyway, which is why I Googled to find the Whiteley Clinic, which I am hoping to get to really soon.
I'm currently working with infectious diseases specialist Professor Jack Lambert to treat persistent infections. This is common in ME/CFS and it's likely central to my case due to immune dysfunction and chronic inflammation. I'm also addressing immune modulation and orthostatic intolerance, OI. This is guided by Dr. Peter Rowe's work on dysautonomia. More recently, however, with this Rubik's Cube of an illness, I've been exploring a potential structural factor, poor pelvic venous return. Now, my arm and lab results show clear signs of chronic infection, immune imbalance, all consistent with the ME symptoms. What is driving this is what I want to know. It's all well and good treating it, but what if it's structural and it's an issue that's just going to keep coming back?
There were so many questions I had. I don't want to fit them all in, but one thing I definitely wanted to ask you is during the scan that stood up, well, two things. How long do you have to stand up for? And is it would it be good to be on your period or be ovulating? Because that's when the pain for me is the worst.
The first one is the whole cell Harrison protocol. You don't stand up at all. What I actually do is, I know there are some people saying you should do it. It's just ridiculous because you'll get all sorts of, as soon as you stand up, you get all sorts of muscle contractions just because you're balancing to stand up. So it's actually done, you're lying down, but it's at 45 degrees. So what happens is you're not flat because that would flatten the veins, you wouldn't see reflux, but it's at 45 degrees. And then you stimulate it by either doing what's called a Valsalva maneuver, which you go like blowing against a straw or closed glottis, and that pushes the blood the wrong way. So we can see if it's going to go that way or the valves close. And the second thing is what's called a Kegel squeeze, which is where you suddenly clench your buttocks and let go. And then from that, we can actually work out the flows inside using the transvaginal duplex. So that's not a problem, that one. Now, what's very interesting is your question about the period, not so much the ovulation, but the period. Because Judy Holdstock, who is probably she is the world leader in this scan. She invented it. She's Holdstock of the Holdstock protocol. And in fact, if it wasn't for her, we wouldn't have anything like the knowledge that we've got. I've worked with her now for 25 years. And what she noticed that if you've got borderline reflux, if we're not quite certain about your reflux, if we get people back and they actually have the scan when they're having the period, the reflux is much worse. And at first, I sort of thought, oh, is that right? But there's a paper that came out in Russia some time ago on leg varicose veins, and it actually showed that if you do a scan on someone's leg varicose veins in the morning, and then you scan the same person in the afternoon, you get a different result. It's worse in the afternoon than the morning. And it's got a thing called orthostatic pressure. And what we're starting to realize is that, if you had, say, a broken bone, you take an x-ray and the bone's broken or it's not, full stop. But when it comes to veins and venous function, it actually does vary very much with how long you've been up, how long you've been standing, and in pelvic veins, definitely in women, at what time of the cycle you're in, and how much blood flow there is in the pelvis. So, in fact, it's really interesting that we've always grown up, that we take a test and that test is the answer. But it's a bit like taking like a blood sugar test. You take yourself's blood sugar and they say it's 6, and it's 6. But if you take it 2 minutes later, it might be 7 or it might be 5. You actually need to monitor things because most things in medicine do fluctuate, and you're only taking a single snapshot. So we are starting to learn that, there are better times and worse times to do scans. Obviously, if you've got gross pelvic congestion, we're going to pick it up no matter what time of the day. But if you wanted to say, right, when's the optimal time to do a pelvic congestion scan with transvaginal duplex, it would be Holdstock Harrison, prepare the bowel, but do it on the period when you're actually bleeding. That actually gives us the best results.
Okay, brilliant. Because I was trying to coincide my period, which is, I mean, that's difficult in itself when you've got mild
Consistent.
can't even speak. When you've got that syndrome, PCOS, because obviously if you're going to pay to get it looked at and seen properly, you want it to be the best it can be. So you
Of
can rule
course,
it
of
out
course.
ideally or get it diagnosed and treated. What's the name of the gynecologist you mentioned earlier when you were talking about the one that's just joined your team and
Yeah,
presented?
Sophie Strong. Sophie
Ah,
Strong.
okay. So interestingly, Sophie Strong was the first person who came up when I was doing my research, which then led me to you.
Yeah, well, so we've been promoting her heavily. So Sophie, I've known Sophie since she was, I think, 16 years old or 17 years old. And she came to me as a patient with something completely unrelated, but was one of the brightest young ladies I've ever met. And her father and mother wanted her to go to medical school. So in 2010, she came and worked with me as a research fellow. And I gave her some research and she published some work with me on something completely different, on veins, obviously. Then she went to medical school because she got to medical school because if you do research, it helps you. And then she came back to me when she was a BSc student in about 2013, and I supervised her BSc. And then she came back and she keeps on, we've kept in contact ever since. And then when she went into gynecology, we kept in contact and we were going world famous for all our work. I sit on the UIP Pelvic Congestions Committee and I've written the international guidelines in 2019 with the other people on the committee. And then she came back to me and said, I've gone into gynecology, as I said, we always kept friends. She said, can I write a paper with you? So we wrote the paper that's just been published. She won the silver medal at the British Gynecology meeting and did very well with it. And that was a paper where we showed that the pelvic congestion doesn't just affect women who have had children and who are fertile. 10% haven't had children, and 25% are postmenopausal. So we're always blowing apart these old wives' tales about pelvic congestion. So she won a prize for that. And then she got a consultancy, but she's in her gynecology side. She's gone through and become an expert in endometriosis treatment, in pelvic and polycystic ovaries, and all the gynecology side. But from our side, she's always kept in with our research on the pelvic congestion. So she's probably the only person in the UK who's doubly qualified in pelvic congestion and in the normal gynecological causes of pelvic pain. So whereas I'm an expert, a world expert in pelvic congestion, I don't know about all the other, things that gynecologists get, whereas she knows both. So basically, for years, we've been talking about it, and she said, look, as soon as I qualify, I want to work with you and get the research done. So she's setting up in our London clinic, she's setting up a female pelvic pain unit, which has all of our resources for pelvic congestion, but also has all of her resources for endometriosis, adenomyosis, and all the other things that she needs to do. So she's got this phenomenal niche in the UK, being the first gynecologist who's doubly qualified in both areas.
Okay, so with the emerging data on ME, POTS, and potential overlaps and crossovers, that I've been very briefly introduced to more recently, are people like yourself and Sophie Strong taking that into consideration too?
I think that's where you have to talk to Sophie, because I've got I basically, the Whiteley Clinic has got many areas of research, and we're world leaders in about 4 or 5 different areas. And I've also invented some new instruments, and which are coming out next year. And so I've got sort of my time is is spent sort of on a whole load of things. But what I do is I surround myself by world experts or people who have the potential. So that's why Judy Holdstock, her thing, and Charmaine Harrison and Angie White, they're all, these three sonographers have come up and they diagnose everything. I'm handing over, so male pelvic congestion has gone to AJ Pankana, who's one of my colleagues, but is interested in that. And the female side is going to be led up by Sophie Strong. So as you can tell from the thing, I'm older and I'm sort of getting towards the end of my career. So I'm taking on these people to guide them, to make them absolute world experts. So they're already, Sophie's fantastic, but she's young, she's on top of her research at the moment, but she also is getting to a position where she's going to become, a major force in the world of this. So what she's doing at the moment is she's already saying, right, these are the areas that I'm interested in, and she's going to be investigating them. So we don't have all those answers yet, but without doubt, absolutely, she's putting all of these together because she needs to, her career will be based around how do I separate these into which are linked together and which aren't linked together.
Okay, whether or not I have pelvic congestion syndrome, I will, as best I can, attempt with everything I've learned. I think it would be criminal not to try to educate or use my platform, because I do that with chronic illness, having
Yeah.
experienced what I have for 7 years. Now, if I do have it, even more so, again, because I can show what I'm doing and how I am after the treatment, etc. Would you be able to sort something out so I can chat to Sophie at some point?
Yeah, of course, of course. I'll introduce you. I'll introduce you to Sophie today. If you have pelvic congestion syndrome, what it's really worth doing, it's really worth then getting the treatment. As with all things, you get an improvement straight away, but it's only mild. And then the improvement, as everything settles down, you get more and more and more improvement over the months to years. And we've had a recent actress who was unable to stand for more than 30 minutes, and she had her pelvic congestion treated. And she went to about a month later and was doing her whole evenings up at the Edinburgh Fringe. She went in the newspapers and said, "This is," and that was one of our patients. And we've had all sorts of these amazing sort of stories of how it revolutionized. And then we've had other people who say, well, it made a little difference, and then a year later, it's, oh my God, once the inflammation settled and the pain, it's just fantastic. So one of the things, when you've got lots of symptoms such as yourself, what's interesting is if you have pelvic congestion, fix that, because you can fix that easily, and then see what you're left with. Because if you've got no other symptoms, it's like, oh my God, it was all PCS. If you say, well, yes, it did fix this, but these are other things, then that's something that's not directly related. So that's the fascinating bit at the moment is, which bits are related to which.
Well, absolutely, but I'm not entirely sure it's black and white in regards to if something fixes something, is it not totally related? Just because looking at the persistent infections, which I know I have, and the congestion loop and EBV activation and metabolic reprogramming and the UTI overlaps, it's almost like if I really listen to my body, I feel like I'm stuck in a vicious circle, and that actually what might come of it is that, yeah, I've got pelvic congestion syndrome, but that links to the stress on the immune system, the EBV reactivation. Like maybe it is things, I don't know, can you have
Yeah,
two
but
things at once?
that's very common. So you quite often have in medicine things like that. And so if it is the chronic inflammation in your pelvis that's causing all that, then of course you stop the chronic inflammation by something you can do, which is coil embolization, and suddenly then the immune system recovers. So then therefore you don't, and you can actually break the whole of the vicious cycle. And that's one of the things that we see all the time when you find, and that's what surgeons, what's slightly different between surgeons and physicians is what we're looking for is, it's like a bit like engineers, a plane's crashing or can't fly or whatever. And, because there's lots of things wrong, but you find it's all down to one central set thing. And so we're almost like the engineers of the body. We're saying, right, what's the major thing? And more importantly, what is it we know we can fix? There's no point in pontificating, sitting back and saying, let's try a bit of steroid, let's try a bit of this, let's try a bit of that, which we don't really know how it works. We don't know what the long-term effects is. If there's something major wrong, fix that first. Fix all the things you know you can fix. And then after that, when you get to the point you can't fix anymore, that's when you start doing the little sort of play means. But that's where you will only know that when the patient has had the treatment, the reflux has stopped, and you've given time for the inflammation to settle down, which is usually sort of a year to 18 months later. But you get most of that inflammation settling down the first 3 to 6 months. The thing to remember is, although you get an instant improvement if the reflux is stopped, you don't switch off the inflammation straight away. And so a lot of people say to us when they've had the pelvic embolization, it's a lot better, but I've still got this ache and I've still got this. And you say, well, yes, because if you had a scar, like appendix or cesarean, it wouldn't look great at 14 days. So 2 years, and that's what happens. That's why we get so many people coming back. I mean, we've had loads of people who can't get pregnant, for instance. They just can't get pregnant. They've tried everything, they can't get pregnant. And we sort of say to them, in the old days, we didn't like doing pelvic embolization. We weren't sure what happens to the cause. We now know it's safe. So we said, oh, don't get pregnant afterwards. They said, oh, don't worry, I can't get pregnant. I've been trying for years. You then go do the pelvic embolization, and the next thing you get is a letter from them saying, "Oh, it's great news! I'm 4 months pregnant." And what they've done is once you improve the blood supply in the pelvis and take away the pelvic discomfort, we know the fertility increases. We can't measure why, but we know it happens, and we've just got a whole load of people who were so say infertile and they just couldn't work out why, and then they have pelvic embolization, and 6 months, 12 months later, they're pregnant.
Yeah, so I have unexplained infertility as well. So that would probably make sense again with the history.
This dual focus, treating infections and investigating vascular dysfunction, is shaping my current path as I twist and turn the Rubik's Cube.
I would love to talk to you again whenever you can. I could probably talk to you for bloody hours, to be quite honest. So yeah, if you have the time, I'd love to arrange to chat again.
I'm actually keynote lecturer for the Australian College of Pathology this week. I'm just about to fly to Australia and I'm giving 7 lectures as their keynote lecturer, but I'm back in about a week and a half. So if you remind me, and then we can talk again when I come back from there. All right.
Yeah, that would be really nice. Thank you.
That's lovely. And what I'll do is I'll put you in contact with Sophie as well now. Okay.
Yeah, thank you so much. Thank you. Have a lovely rest of your day.
Take care. Bye bye then.
Thank you. Bye bye.